We have a keynote address also in this session. May I invite Professor Dr. Nitin for his keynote address, and our apologies for, I think, for next session chairperson and participants. And Dr. Reddy, can you briefly introduce, sir?
Hobart Eye Surgeons from Hobart is a clinical professor, general ophthalmology, cataract, oculoplasty, and he'll be talking about intraocular pressure raise following intravitreal injections.
And I'm sorry, but those videos were they were really fascinating, and I don't do that anymore. But I'd like to bring your attention to the issue of intraocular pressure with repeated intravitreal injections, and just thinking of pressures running for 80, 90, 100 millimeters of mercury for some time. I was thinking, gosh, this can certainly cause problems with the optic nerve. So intravitreal injections are now it's part of life. They produce great results, great outcomes. We use them for almost everything that would respond to them. But do we really think of the short and long-term effects of intraocular injections? So this is really what I wanted to talk about. And most of us don't really check the intraocular pressure after injections. We are dealing with an older population, we're dealing with a vulnerable population, and especially a lot of people in this age group that we deal with and with the morbidities we deal with have glaucoma. So each time we carry out an intravitreal injection, the pressures can go up to astronomical levels. This is what happens with an intravitreal injection of triamcinolone, which is really the volume of 0.1 mil. But within 20-30 minutes, everything comes down. Does it cause structural changes? The answer is yes. It changes the Brooks membrane opening, not only at the first injection, but after first, second, and third injections, and the effects are even visible 1 year later. There's also a slight reduction in RNFL thickness. Why does this intraocular pressure rise occur? It occurs simply, you inject volume, but it could also be due to biochemical changes. It could be to the fact that we're using high molecular weight proteins, structural changes. And in fact, when you use a syringe, it moves quite smoothly. And that's because it's got particles of silicone and lubricants inside. And these also have at times caused clusters of elevation of intraocular pressure. Remember also that when you inject, sometimes you see a reflux and you quickly try and stop that reflux with a cotton bud or something. Is that good? Is that bad? But we know that with reflux, the intraocular pressure after injection is lower than without reflux. But also one worries about, has a bit of the drug come out? Does this reduce or increase the risk of endophthalmitis? But certainly reflux is part of the deal. Some examples of patients whom we've been monitoring for glaucoma, patients who had intravitreal injections, and here's an example of one. But we also have patients where the pressure doesn't rise. And after injection, there is a one-eyed patient whose pressure would be in the 20s, 30s, and then he'd go to no PL. So we tried using a Honan balloon, you're all familiar with, but then found that just using a simple intraocular pressure lowering drop that we use for glaucoma given 2 hours before seems to work equally well. Sometimes you think maybe I'll inject just that little bit less, but that also does work. And the effect of these glaucoma drops lasts even up to 2 hours after the injection. So it doesn't matter which drop you use, but it works. So it seems that short-term pressure spikes are not a big problem. And where you are worried, you can pre-treat with some glaucoma medication, and that will give you the desired buffer. But patients who've got glaucomatous optic atrophy already would be a problem, and they're the ones that you need to be careful about. So let's look at the long-term effects. All the pivotal studies did not address this issue simply because many of them excluded people with high intraocular pressures. And if you look at it, you don't really get any answer from these very controlled trials. The American Academy also tried to look at what happens with intraocular pressures in the long term, and they came up with basically no definitive answer. And also there's a significant variability between studies because they use different criteria, different machines to check the intraocular pressure. So we really don't have much to go on, although some meta-analysis did try to address this, but you find that they didn't consider glaucoma as a risk factor and studied that to see what happens. So we thought, well, let's look at our own patients. So we looked at patients over a 10-year, 11-year period, really the results of over 20,000 injections to see what really happens. So we're really looking at intraocular pressure elevation in this time, but then also looked at a couple of other questions that come up. So we had 1,086 patients. Some of them had glaucoma. Really what we found was that our incidence for AMD pressure elevations were less than the diabetes angle. There was no difference in indication for treatment, really, but nor was there any difference in the drug injected. So even though some studies showed that ranibizumab had higher pressure elevation, we didn't find that to be the case. The multivariate analysis also, the confidence intervals and the spread was such that it didn't come out with any answers. But here's an example of a patient who had stable ocular hypertension. The glaucoma indices, functional parameters did not change with time. Another patient who had well-controlled glaucoma, and you can see that we monitor everything, and then again there were no changes. But in a third case where a one-eyed patient who had a retinal vein occlusion, you can see that the visual acuity and macular thickness were pretty good. But with time, the pressures didn't behave very well. And in these patients, you see that the glaucoma indices actually worsened, as you can see over here. So really what it comes down to is the fact that patients with elevated intraocular pressure or at high risk, one needs to be careful with them. So where do we fit in the global studies? That's where we are. We found a sustained elevation of intraocular pressure, which really is pressures above 22, more than 6 millimeters of mercury at baseline on 3 occasions, or an absolute pressure of more than 26 millimeters of mercury. We found that our cohort, it was as shown here. We looked at the other parameters and found that the average number of days from injection is more than a year that it takes for the pressure to start climbing up and misbehaving. Diabetic patients are at particular risk, especially those with higher levels of HbA1c. And this is not our study, but just to answer questions, does repeated injection or a repeated injection cause changes in the outflow facility? The answer is yes, especially in patients who are receiving frequent injections. As you can see here, the outflow facility actually decreases the higher the pressure is with repeated intravitreal injections. Of course, nothing happens without genes and genetics, but we are able to predict in some groups where they are at risk of visual field loss. There were complexes where of sustained intraocular pressure increased based on the presence of silicone and impurities, but once the drugs have been filtered and the silicone removed from syringes, these have not recurred. When ILIA came out, there was this whole thing of pressure rising, and that was because we are used to giving a hard push at the end, and I suppose that if you prime it properly and inject it gently, this problem won't be there. So in summary, I think we found that 117 of our patients developed a sustained elevation of intraocular pressure. The elevation of intraocular pressure was not related to the type of anti-VEGF treatment. It was associated with pre-existing disease and lens status, so glaucoma, ocular hypertension, and phakia. Glaucoma, it was 3.5-fold increased risk of elevated intraocular pressure. and pseudophakia, in a sense, reduces the risk. So the take-home message is really that intravitreal injections, repeated intravitreal injections, can cause problems in selected cases with IOP changes. Intravitreal injections do cause structural changes in the eye, and I think we really need to monitor susceptible patients more closely when we are going on this journey of repeated intravitreal injections. But I suppose the challenge is identifying these patients. So I just leave you with that, because I know, you raise the pressures, but you do it not so often. But with intravitreal injections, it's a long journey. So thank you.
Excellent, I think, topic, and I think quite enlightening. And we have been quite a few reports on this. Like all of us, we are colleagues across India also following this. That we are little more sensitive now towards IOP in our anti-VEGF patients also. Anyway, we were doing it we are observing it very closely for DEXA implant patients. But anti-VEGFs are also, are not that benign. From glaucoma perspective, I think very useful insight. But I think, do you think you will still worry injecting in a glaucoma patient after this much of information and new insights?
Well, you want to make sure they maintain their vision because of the macular problem, but don't go blind from glaucoma. And all vitreoretinal surgeons have seen that good result, pale disc, and I think that is something that we need to worry about. So in selected people, we tend to check the intraocular pressure before they leave the injection area. Especially ones whose glaucoma indices are going downwards. But most people, and another group is where where you're doing bilateral injections. You need to be very careful there, because they may not report anything because the other eye. So
absolutely, and we all realize this, that functional, and I think we have a glaucoma specialist here. So that structural and functional test will fail us once you have a macular pathology and all our cases. So then IOP is the only thing which we can monitor. And so I think when your structural and functional tests are not performing well, so how do you adjust the target IOP? Like, you bring it lower down? Like, should we do?
Sir, if the disc is too much damaged, then we err on the side of little lower IOPs, and we still can follow up on the imaging and visual fields if they are changing parameters, increasing losses.
I'm sorry, Dr. Ankur, to